We are going now to our last speaker, that is Dr. Dagva Mungunchimeg. Very difficult for me, Spanish speaking. So for me, it's Dr. Mongo. Thank you for joining us. Dr. Mongo is head of the Cardiovascular Center at the Shastin Center Hospital in Mongolia. And she is going to address a very important topic those days with the virtual world that we are living. That is cardiovascular telemedicine. And she's going to present the case of Mongolia. Thank you so much, Dr. Mongo, to share with us your presentation.
Thank you very much, Mr. Chair. So next few minutes, I would like to share with you the cardiovascular disease case management using telemedicine in Mongolia. Let me introduce a little bit about our country's context. We have Mongolia is a landlocked country between Russia and China in Central Asia, which has 1.5 million square meter territory, and with only 3.2 million population scattered over this huge territory, and almost half of the population living in the capital city. In this country, wide like 3,000 kilometers from west to east, health sector comprises 574 family clinics in all country, in 34 secondary level hospitals, in green is noted here, and 17 specialized tertiary level hospitals mostly in capital city, and in addition 536 private hospitals also in more populated places. In regard of COVID situation in Mongolia, the COVID pandemic in Mongolia, in January 27th of last year, Mongolia declares the first state emergency and lockdown until early March of 2020. Since February 2020, Mongolian border closed. And 10th of March, a first confirmed imported case of coronavirus was detected. And 11th of November, the first domestic case with the coronavirus detected. And the lockdown is ensured in all businesses except essential services were closed. And so far we have, as of today, 2 days ago, the total number of verified cases of above 2,300, and the recovered are more than 1,600, and 4 deaths for now, and the people currently being treated is 621. Total number of tests done is during this last period of time is over 1.3 million, which is among the patient among the patient with treated now currently, the patient with moderate to severe conditions, comorbidities, in regard of comorbidities, the prevailing hypertensive disease. Early closure of the border restriction in domestic movement and mandatory wearing mask everywhere, public awareness about the hand sanitizing and social distancing since end of the January was crucial measurement in response of to COVID. Since March 2020, 121 charter flights were flown solely to retrieve 21,000 Mongolian citizens from abroad. The main strategy for COVID-19 has been early preventive measures, multi-sectoral coordination, and the partnership in the culture of continuous improvement. Health sector paid special attention to strengthening its national health capacity, including laboratory capacity at national and subnational levels. Considering that the global pandemic is not yet over, Mongolia is doing its best to prepare for better future with everyone acting in solidarity. If you look at the COVID situation of Mongolia in comparison with international context, we have a testing, we have a little bit As an average, as international level in regard of testing, and the low cases confirmed per million in identified. And the most importantly, the absolute quantity of all-cause mortality remains same as previous, as an average of previous 5 years. The rate is showing the whole during the year. And now telehealth and telemedicine. Common telemedicine is definitely, virtual health has been more and more recognizing as one of the suitable model of a new healthcare during and after COVID-19. That's for sure, and especially to help address the rural health needs and narrow the rural and urban health gaps. Of course, there is much more to develop in synchronizing, speeding up the care and physical physician-to-physician communication, chronic disease management, and a virtual social work and telehealth care, and patient remote monitoring wearable devices using the case management process and patient adherence to the treatment and care coordination between stakeholders are all impacted to telemedicine usage. We are in Mongolia, we have been using telemedicine in improving case management of cardiovascular disease since 2001 within the project supported by government of Luxembourg. The main goal of the project was to contribute to better health to the population. In each of these 4 phases has inside a component for developing telemedicine for improving cardiovascular case management. These are the very first team members. And this is a really fascinating project, could substantially contribute in decreasing the cardiovascular mortality, which is actually a leading cause of mortality over last 20 years. And even though last 20 years, the morbidity of cardiovascular disease was constantly growing up. Here's shown how chronologically developed telecommunication software we have been using all these years. Different features were added due to users' requests. If in the beginning it was only a simple program, which allows us to exchange attached files, then by year, it became a form-like platform functioning to seek advice from colleagues and opinions from others in the system, including the reference center. Then it became with the feature of simple e-medical record, with the recording interventional treatment, patients to follow-up sections. Working in one system from different parts of Mongolia enabled physicians to work in close communication in monitoring and caring their patient. I will show current version of the in detail and where we are going to the next slides. Current version of MnCardio program has following features. It has a simple e-medical record features, teleconsultation section, heart team-based patient follow-up, national heart failure registry, and the patient doctor platform. In the recent 12 months during the pandemic, over 12,000 patients registered in the system, and more than 27,000 e-medical recording was in the system. And nearly 300 cases were discussed for a second and third opinion, and beyond 2,500 patients referred to the National Cardiovascular Center for further management. And the National Registry on the heart failure to be launched in common month. Patient doctor platform is under testing. Currently, we tested over 30 arrhythmology cases for with the patients remotely. This is a home page of MnCardio program, where you can see where the active tickets, which means the question posted by other doctors, will be seen first. which is actively discussed clinical case between doctors. Also, the physician's activity is seen on this page. If any doctor encounters a problem using the program, there is also a manual can appear from right bottom, this manual. And there are also the teams, teams for follow-up section. Cardiovascular Center has 5 general types of heart teams, which are valvular, vascular, congenital disease, arrhythmia, and heart failure team. And doctors can incorporate and include their patient into these teams. Also, they can create any teams by their own wish. And 100 to 400, 480 patients are in different teams, actively followed up by different doctors from different places. And this is a registration part where the patient passport information, past medical history, etc., can be registered. As usually medical record, it contains all the questions of a medical record. And it is also developed in a way that to record procedures in an easy, user-friendly manner, like echocardiography is shown here, and also able to attach files, pictures, and even cine images. And there is also the ticket section where the patient file can be converted to the teleconsultation section for the seeking second and third opinions. And there is a surgical also section where the cardiac surgeon can record their patient and also use the Euroscore for risk management and also record their performance surgeries. Same for PCI. It's also easy, user-friendly record the findings and which kind of stand and where it is placed and what to recommend for the rural doctors. And we also integrated to the system medical calculator for support to physicians. And we added also here, due to our doctors' request, that the first national registry we want to launch with the help of National Heart Center of Singapore. This is a heart failure program. We are going to start a national registry in the coming months. And the last section, which is dedicated for the transfer, if the patient transferred to the center or from center back to the rural doctors, this section is used for the comments. And these are the utilization of the MnCardio during the last 12 months. And the blue are the registered patients, the orange are the visits. And if we can see who is asking the questions during pandemic, is majority of the questions were posted from those located remotely. And what are the purpose of what they were discussing is generally they are seeking second and third opinion for the general case management, but also a substantial amount for cardiac surgery and PCI referral in the decision making. And the diagnosis of the posted discussed patients, majority of them is the patient with the ischemic heart disease and also the hypertensive heart disease with the heart failure and arrhythmia patients were triggered discussions. The rural doctors, 80% of their patients, they could manage themselves. Only in 20% of cases, they were either seeking for a second and third opinion or referring to a central level. And among those discussed, I mentioned earlier, among those referred, 62% was referred to get interventional treatment, which were not available locally for them, and 26% cases required consultation from arrhythmologists. So in general, telemedicine could diminish all these steps for rural patients to get tertiary level cardiac care in Mongolian context. This means telemedicine can reduce burden for patients, be cost efficient as it cuts unnecessary travel, and the powerful tool to improve rural healthcare. We are expanding our program vertically in 2 pilot provinces to primary level care, and also horizontally to different subjects, including for COVID patients. These are the activity in those 2 provinces for the communication between family physicians with the secondary level doctors. These are the horizontal extension of a different subject. MnStroke program was developed, is the test and the testing by neurologists, and the COVID-19 telemedicine program is we are advocating for utilization with other hospitals, especially with the National Hospital for Infectious Disease. So our telemedicine project is not only improving case management, but also contributing to enthusiastic professional team building, which is important, especially important during this pandemic time where everybody is feeling isolated. As a conclusion, there are positive elements from our experience. Telemedicine shares the biggest workload of health services, making services accessible, affordable, time-saving, comfortable for patients, meanwhile complying with social distancing and safety regulations during COVID-19 pandemic. Working in the connected network is contributing to professional team building, bridging isolation and improving self-confidence for rural doctors. And putting there as an example, our doctors in the network could work together, national prevention plan, National Cardiovascular Prevention Plan, which was actually approved by Minister of Health. And we are celebrating the World Heart Day already 3 times together with the World Heart Federation, and we are actively disseminating all the messages to our population. In country with a similar context as Mongolia, telemedicine is a useful, cost-efficient tool for improving case management of chronic disease and secondary prevention during and after COVID-19 pandemic. Virtual visits satisfy patients as well as physicians during this pandemic. But there are challenges, even though telemedicine is becoming an even more futuristic tool for health services like visits, follow-up, chronic disease. Not every service benefits from telehealth. And physician-to-physician support depends on the personal commitment of physicians and their workload in the rural settings. Equity of reimbursement for virtual visit, consultation between a physician for second and third opinions, and the relevant regulations are essential for further beneficial utilization. Security of private health data is another concern for many patients. Strong support on teleconsultation, telehealth from healthcare providers and internet service providers further needs to be increased. Percentage of patients who can use telemedicine program are still limited, particularly among low-income and the rural patients. Thank you very much.
Thank you so much, Dr. Mongo. A very nice presentation.